go through briefly what my approach is to doing acute iliofemoral thrombectomy. I do say iliofemoral because that's the way I practice, and certainly now we are supported based on the ATTRACT sub-analysis. These are my disclosures. So when I look at a patient, I think of these four areas. I need to know the answer to these areas before I even put the patient on the table. So what is the history of the current presentation? If this is somebody that has had prior DVT in the past, then you know you're going to be dealing with something much more chronic and is much less likely to respond to traditional thrombolytic measures, and so you have to prepare for that. If they have other comorbidities, if they're outside of the symptomatic window, if there's extension to the iliofemoral segment, and of course, what is the causative factor? Is it one of the compression syndromes, which is anatomic? Is it pathologic? Certainly, there could be a tumor. We've seen that in our centers, and I'm sure many of you have as well. And then, of course, the most common man-made reason for iliocaval and iliofemoral DVT, which is an inferior vena cava filter. So these are all things you need to know because they're going to change your procedural approach. Imaging is absolutely critical. You'll hear at many meetings that you can image the iliac and cable segments with ultrasound, and while I think it's possible, you have to have a very high degree of local expertise to do that. So in my center, we use CT venography for imaging confidently above the inguinal ligament. Duplex ultrasonography is obviously to image our inflow, and then other tools as well. Intravascular ultrasound is most important in the procedural suite. So how do I do it? Well, I looked at trials to time my intervention. The ATTRACT trial included patients up to 14 days. There's an asterisk to this statement, caveat, which is that I firmly believe that patients organize clot at different rates. Organization of clot is an inflammatory process, and younger patients have much more exuberant inflammatory processes. So they're going to organize clot, which is going to get rubbery, at a much faster rate than more elderly patients. The CONVENT trial went up to 21 days. Certainly that's possible in older patients. Know if you have chronic DVT because you're going to be less effective with your thrombectomy devices. Contraindications to keep in mind: metastatic disease, of course, whether they have active bleeding, that's something you're going to want to take into account and potentially just do a mechanical approach. And pregnancy, active pregnancy is a contraindication, but certainly in the postpartum stage, you can do it. I have done it in those states. So my case is actually fresh, relatively fresh, about 2 weeks ago. This is a 29-year-old female on oral contraceptives who presented with 10 days of left leg edema. She was traveling to New Mexico the preceding week, and she noted there that her left leg was red and purple in color, potentially may have been phlegmasia. I didn't see her at that initial presentation, nearly doubled in size. The duplex demonstrated what we would expect, which is left femoral and common femoral. They did not image above the inguinal ligament. Not sure if they made the attempt or not, and she was discharged on rivaroxaban. She then comes to me with progressive pain and swelling. She has suprapubic bruising, and we do a CT venogram. So this is kind of going fast, and I'll slow it down, but it's similar to what a Keyes picture showed, which is a compression syndrome, and then as you scroll down, there's it's sort of stuttering here, but you see acute thrombus in both the internal and external iliac veins extending into the common femoral vein. So I keep these patients on anticoagulation through the procedure. I think it helps to have that baseline level of anticoagulation. I supplement it with intraprocedural anticoagulation. I like to administer intravenous fluids with bicarb, and it's primarily dictated by my device of choice. And again, you've seen that there's many different ways to do this. I like the angiojet device, and the bicarb is specifically there to alkalinize the urine to sort of mitigate the effects of rheolysis and the hemoglobinuria. I prefer small saphenous posterior tibial, and my last resort is popliteal access. I perform venography to confirm the extent of thrombus, and nowadays with our newer stents, I use a 10 French sheath right off the bat. So this is how it looked. Everything below the profunda was open, but you can see the common femoral vein is subtotally occluded. There again, you see the tram track sign. We cross. I use typically for a single limb, I use 10 milligrams of TP in a 50 ml saline solution. I let that dwell for 30 minutes if I'm lucky, although the over-under on the last time, I think on this case, was about 11 minutes. The fellows had a bet going on me. And then I go to rheolytic thrombectomy, so you hit the alarm reset on your console, it switches over. Don't do the rheolytic thrombectomy with the TPA bath, you do it with conventional saline, and we start clearing it out. And you can see, similar to a Keyes case, that there's still acute clot there above the inguinal ligament. And so in these cases, I actually kind of think to dialysis work, and you have what we know from our imaging is that you have a compression point. So I use that as an autoprotective measure, and then I take a Fogarty balloon, to actually peel that adherent clot off and push it towards a compression. I stop short, I don't push it into the cava, but I push it up there, and then I take my angiojet again, thinking that that clot has been detached, and then I clear it out. Now, I don't think that I will be able to clear all that clot out of the common and proximal external iliac vein. I just don't think that, I think much of that is organized, probably from the chronic compression syndrome. So in these cases, I just move forward with performing IVUS and then stenting. One thing I like to do before I place my stent, I like to map out exactly where my stent is going to be. And certainly IVUS is very helpful for this, but I actually just like to use a reverse curve catheter, or old-fashioned technique. Center, so that you have no parallax in your imaging plane. I do a simultaneous injection from my sheath as well as my reverse curve catheter. It shows your anatomy beautifully. It's in the center of your field. I lock the table there, and then I pick my stent. In this case, I use one of the newer stents. This is a 14 millimeter by 120 Vichy stent that we post-dilate to 14, and here you can see the final picture. So important, usually 3 to 6 months of anticoagulation. We do it for 6 months generally. My goal is to do it in a single setting, and that's particularly predicated on the ATTRACT data, because the ATTRACT data showed us that there was no Guzdo-5 bleeds, whereas Covent had those bleeds. So I think at least one way I look at it is that patients tend to have much less bleeding risk if you use pharmacomechanical technique over conventional catheter-directed therapy. Okay, thanks.